Respected elders, chiefs, health service executives, ladies and gentlemen. I'm Barry Phillips. I'm with New Views Consulting, and I've had a contract now for the third time as the CEO of the Bigstone Health Commission. Lyle, my co-presenter here, is also a former CEO of the Bigstone Health Commission, the Director of Non-Insured Health Benefits for Alberta Region, and a former senior manager as a Chief Financial Officer for the Winnebago Regional Health Authority. Excuse me. It may seem strange when I said that I've been the CEO for 3 times at the Bigstone. And that really points out the first issue we encountered when taking over all aspects of the management of the total health programs at the Bigstone. The first issue is and still is finding someone who can operate a complex health organization that consists of public health programs, not-for-profit, for-profit, and charitable organizations. You, of course, will have a tremendous advantage as the size and scope of your endeavor will allow you different people with different skills. The training, education, and experience that Lyle and I had were different, but they did include a mix of health management roles that suited our needs. In the booklet that we were given to read when we were here a couple of weeks ago, on the back of that booklet covered highlights both the reason and need for change. And I hope that our presentation will show you that the outcomes wanted are all possible through this process. First, we wish to thank you for the opportunity provided to us to meet with you today and share our experiences in managing the programs at the Bigstone. We're excited to be part of this gathering as we too seek wisdom and know I will learn much from these few days with you. The need for change has been well documented and discussed for many years. Lyle and I met 14 years ago when we both served on various joint AFN Health Canada subcommittees that led to the NIHB transfer pilot projects. We were fortunate then also to meet a few of your health directors from British Columbia that served on some of those same committees. Our presentation today then will be mostly about our NIHB experiences. Firstly, because that's what we were asked to come and talk about, and we like to keep the organizing committee happy. And secondly, because that is where the greatest challenges and opportunities lie in meeting your outcome objectives. The Bigstone is 7,200 people amongst 7 communities. The farthest community is 50 kilometers away the way the crow flies. Unfortunately, the crows did not design the roads in Alberta. It is 350 kilometers away by road. Calling Lake, 125 kilometers to the south and east. Sandy Lake, 30 kilometers to the south. Reserve C, 30 kilometers to the north. And Chip Lake, 90 kilometers to the northeast. Reserves A, B, and D are located on the north sides of the Wabasca Lakes. For some of you that were watching the news last week about the fires in northern Alberta, Wabasca was mentioned at that time as having to have a partial evacuation. We do reside north of Slave Lake. And in fact, the vehicles that couldn't get through Slave Lake were rerouted to go up around through the Wabasca area. The motivating factor for change began with a Treaty 8 meeting some 20 years ago, when the then regional director for MSB stated that the least well or sickest communities in the region were those of the Bigstone. For a young, newly elected chief at the time, Gordon Auger, it was a shock. He stood up, said, "I'm going home and I'm going to fix my community." Shortly thereafter is when I got involved with the Bigstone and First Nation Health. It didn't take me long to realize what, of course, you people have lived with and what you realize, in that there is a scarcity of resources, a bureaucratic system with little flexibility for change. Of course, it is important to not underestimate the risks associated with taking transfer of NHB, but it is equally important to not underestimate the advantages and opportunities that are available for First Nations when they do take this opportunity. Lyle?
Thank you, Barry. I'm sure most of you are NHB certainly has both its risks and administrative challenges in doing this. Today, we would like to highlight some of the opportunities that you have to deal with improved service and the impact the opportunity has on improving the terms of health for your community. Early on, Bigstone recognized that there are two streams that you can take an opportunity with regards to non-insured. These streams, one is the actual delivery of the program for the payment of goods and services, and the second is actual business of delivering these services and the profit being made. What Bigstone did, as you can see here on the right, you see Bigstone Commission Board of Directors. This is a nonprofit company. This company delivers community health services and also is the primary signer of the non-insured agreement. They provide the benefits of this program to the First Nation members. The other side is the for-profit side, Bigstone Health Holdings. This holds a number of companies that benefit from providing services on a retail basis. This structure here, because due to the size of Bigstone Health Commission, there's only one executive director that oversees this whole structure. So currently the CEO, Barry here, oversees both the profit companies under Bigstone Health Holdings, which are Bigstone Pharmacy Limited, Bigstone Medical Transport Limited, Bigstone Dental Orthodontic Limited, Bigstone Professional Center, and Bigstone Vision Care Limited. And the remaining sections are the companies or services that are under Bigstone Health Commission. What do we mean by business opportunities? Health Canada basically runs an insurance program. They establish rules around what is covered and what is not around non-insured. They determine how often they will pay for services and what extent the service will be provided. They are not in the delivery service business, and therefore the $135 million they spend today on your behalf is basically paid out services provided by others. Their costs are impacted by rising costs of goods and increased demand by service providers. The revenue is determined by government budget process, and when revenue is less than cost increases in services, then some services have to be dropped or reduced. There is no other source of income and no control on service delivery cost when government manages this program. They are essentially buyers of goods and services and not providers. So the first question, do they do a good job as buyers? Are they getting the best price? Can they negotiate as well as you could? One would think, because of the size of government, that they should be good at what they do and can assure that they have the expertise. But can they really accept the rates proposed, or is it political fallout from a strong lobby, ways to total bargainers? Do they really have options? We suggest not. But an organization as yourself can. In Canada, health is a big business. Just to give you an example. In Canada, the retail market for prescription drugs, OTCs, or over-the-counter medications, and vitamins in 2010 was $27 billion. In that same period, Health Canada spent $435 million on non-insured pharmacy benefits. This amount only represents 1.6% of the total retail market for retail pharmacy in Canada. Yet, First Nation population in Canada represents 2.5% of the overall population. So So we are often told to believe that the health of First Nations is lower than the average Canadians, yet the 22.5% of the Canadian population and the cost source represent only 1% of Canadian sales. So, yeah.
Health is not only a big business, it is a profitable business. Because I'm here in Vancouver, I assume most of you are Vancouver Canuck fans. Very delighted ones, in fact, today. Unfortunately, I'm from Edmonton.
Condolences.
But our team is owned by Daryl Cates. Does anybody know the name? Yep. Daryl Cates owns the Rexall Group of companies, Rexall Pharmacy. 22 years ago, when Daryl was in university with my son, he was not a billionaire. He was not a millionaire. In fact, his dad owned one pharmacy on 124th Street and Stony Plain Road in Edmonton. Today, his estimated wealth is $2.43 billion. A very successful businessman. Like any business venture, you have to start somewhere, and I guess one pharmacy is a good place to start. Bigstone's opportunity came in 1996, when it was only one of 17 communities across Canada chosen to deliver the NIHB program under a pilot process. Initially, Bigstone administered only the medical transportation program. In the first phase of the pilot projects, we were allowed to pick and choose what benefits we would like to try and administer. This was our option that we chose so that we could first address the issues of access. However, in the second phase, the government required that the ongoing pilot projects must deliver all programs under the NIHB. This then provided us the opportunity to expand services and focus on the determinants of health. Unfortunately, only one community became operational after being approved to proceed in phase 2, and that was the Bigstone Health Commission. To proceed with phase 2, the Bigstone Health Commission decided to develop its own adjudication system and train their own staff for pharmacy instead of using an external provider like an insurance company, as their costs would equal the amount provided by transfer. And by doing so, the Bigstone Health Commission realized an immediate savings that would, in percentage-wise, in the volume that you're talking about, the expenditure levels that you're talking about, could result in an immediate saving of around $2 million. They also developed the vision program and used the medical transportation system that they had developed in the region to improve service. Realizing the importance of good fiscal management and the need to have information on a timely basis, the Commission went out and directly recruited the right person for the job and hired Lyle away from the Winnebago as their Chief Financial Officer. His knowledge of the federal health programs and the process which we were in as a result of having been at those joint subcommittees was necessary if we were to move forward. The challenge of management is great when you take on such a responsibility. Lyle eventually became the CEO for the Commission and transformed the management structures to be able to respond to the complex issues that face the type of enterprise. Unfortunately, Lyle followed 5 other ex-Bigstone employees to Health Canada, where they all held or still hold senior and mid-management positions within the Alberta region. We believe, however, that this proves that the Bigstone methodology and implementation of the project was well recognized by government as quality and effective delivery of services.
And just for the information of everyone, I've actually no longer worked for the government since last September. So. So early on, in going forward with the pilot project, there's a couple of initial key success factors that were important to Bigstone to succeed in the pilot project. The first one was communication to providers. It was very important because one of the biggest things we had to ensure there was no interruption of service. This was important not only to government, it was important to our members, and it was also important to providers to ensure that they got paid. Another aspect that was viewed as success was the great cooperation that Bigstone received from Alberta Health Region in developing the administration and training of local staff. Their involvement was certainly key in succeeding. Equally important is the support that Alberta Region provided in terms of data, providing the necessary data to populate the Bigstone systems, as well as they assisted in a number of systems that were in place at the time. Like I said, the initial focus was to ensure that the transfer from NIHB from Health Canada to Bigstone was seamless. However, to ensure that you have the ability to improve on the outcomes desired, you'll also want to ensure that you move forward with your own ideas that may be different from the way of government. You'll need to demonstrate some initial success so your members will see value in the transition. Evaluation on your progress will be measured by both government and your members, and the time allowed for you to prove yourself will be limited. Bigstone enjoyed very positive evaluations, which brought confidence to our program and the people we had administering them. As earlier stated, Bigstone first chose to take on medical transportation services. First, we saw opportunity for efficiencies, and secondly, we saw the ability to use this program to improve access for the membership. An example of what we did in the area of ambulance services by upgrading from emergency medical response to basic life support service and eventually to advanced life support. And what that allowed is that in the community of Wabasca, there was always a paramedic on shift for each of the ambulances, which was a good increased level of services. We moved from providing services to one community to providing services in 5. The opportunity to administer programs differently from government was, of course, our first desire. Health Canada plans in silos, and in fact, there are even silos within the NIHB Directorate. You sometimes wonder if the various departments even talk to each other. For example, Health Canada has and continues to talk about the risk of health around obesity and infant weights, but the first line you see in the pharmacy handbook for NIHB under exceptions states that they do not and will not pay for weight loss medications. Just demonstrates an example where the community health side is certainly not always consistent with the program delivery of non-insured health benefits. Another opportunity that exists with regards to administering non-insured is the ability to collect and maintain raw data on each NIHB transaction, which can be used for integrated health planning specific to your needs. Health Canada collects information on every transaction of non-insured, right from who prescribed it, the pharmacy that you done, the drugs that were taken, as well as the quantity and drugs produced. But yet, this data is not primarily used with regards to primary healthcare development. Health Canada does not do any integrated planning with their information. However, we do. An example is we mine the pharmacy data to identify diabetic clients, who are then flagged in the vision care system that they are eligible for an eye exam every year instead of the current 2 years. So when a vision care provider contacts Bigstone Health Commission to verify eligibility of client, the client is flagged as eligible and no additional documentation is required. In Health Canada today, the vision care provider, at least in Alberta, is expected to provide proof that the client is diabetic before the additional eye test is done. So it's one way of certainly improving the process around exceptions.
Found deficiencies within our system can be reinvested in enhanced benefits or redistribution to community health services. NIHB can create community wealth and economic growth. Value created by the companies is community owned. Bigstone has added $5 million of paid assets to their balance sheet. It has also added over 100 jobs with more than $3 million in new or repatriated salaries and wages. An example is Bigstone started with a local dispensary with 1 employee out of a trailer. Today it has a full retail pharmacy with 10 employees, and the business grew from $600,000 to $2.5 million in 2010. Independent from government, you can maximize the purchasing power your $135 million would provide. You can join buying groups, provide alternative service delivery models, get in business of providing services to your members and others in the community, and by reinvesting the profits, enhance the services you already provide in your public health programs. Yes, I said profits. Not a word that government can use, but not a dirty word that we cannot use to build on the strengths of your community. When was the last time you saw a pharmacy fail? Or a pharmacist not be able to go to Hawaii for his holidays? Have you met any of these providers that live in substandard housing or can't afford to get their cars fixed? How many of these service providers are employing your people? Determinants to health say you need earned income. But how do you earn income if others provide the service and your system simply pays for it? More than 50% of the price of a prescription is funds over and above the cost of goods. It pays the rent, but do you own the building? It pays the staff a salary, but do you get the jobs? It pays the professionals, but do you get to train for those jobs and get the benefits? It provides the profits, but do you realize any of them? In most cases, the answer is no. But you do get to have the government pay for them to have these advantages. Why then do you not build the building, rent it to your own provider businesses, train your staff, and secure the jobs and use the profits to enhance your program objectives? Can this really be done? Ladies and gentlemen, the Bigstone did it. And speaking of the pharmacy program, excuse me, government is restrained by regulations designed to ensure they cannot be faulted for an expenditure they make. So you have to go see a doctor to get a prescription for aspirin, so they can prove it was a needed product that they are paying for. And because it is a medical appointment first, you get medical transportation. And if the doctor is far enough away, then you get accommodation and meals. And when you finally bring the prescription back to the pharmacist, he gets 11 or 12 bucks for filling it. Oh, and the $4 the aspirin cost. Here's an example, with all due respect, sir, that only the government of Canada could design a system that makes aspirin cost over $50 a bottle. Surely you can do better. With our pharmacy, we improved access. We improved on the cost of goods and services in the community. We employ members in all positions available. With more than $150,000 each year in profit, we enhance health programs on our reserve. By the way, that profit is after we have supported just about every fundraising activity that can happen in your community. Being a good corporate citizen is important to the image and pride we take in being a quality provider of service. We got tired of our members receiving less than a quality dental service. We employed dentists, trained members to be registered assistants, and opened the doors in our building with our business and provided a higher quality service to all members in the community. The business employs our members, pays rent to our building, and our adjudicators approve what's needed to be done to ensure a proper dental treatment program for our members. These profits from businesses also go to enhance other health programs. An important phrase within this note was to provide services to all members of the community, as we are not adverse to making profit on non-members also. The Bigstone size limits us in what all we can achieve, but a transfer of NIHB on a scale that you are talking about opens many more doors for you to improve access, service delivery, employment, and profits. Health Canada limits crowns for your members. Crowns come with a lab cost of around $400. That's over and above your dental costs. However, here's the next business opportunity. John, I told you I was going to use it. There is a machine that makes a better crown than the one you get now. This is a solid piece of ceramic, 7 times stronger than liquid ceramic when they make your crown now. Yes, it does take a $100,000 capital investment for a machine, but when finished, that crown is $40 out of the lab, not $400. Somebody is making a lot of profit, but it's not you. Somebody has the jobs to make these, but it's not you. Somebody is paying rent for the lab space, but it's not you. The machine costs $100,000, and it would take Bigstone 2 or 3 years to see the benefit from it, but it would only take you 2 or 3 months. We're going to do it anyway because in the long term it makes sense for our clients. But for you, it would immediately reduce your costs and make money also. Oh, and don't forget the jobs. For your members, and the fact that you own the lab. I was going to give you an example about vision care, but it's moving along. But these are Oakley glasses. You see those all the time on the Indian wall of glasses, right? No? Why not?
Don't call it that.
Awesome. Well, these are from Vancouver. It's possible to get Oakley glasses within the budget range of the Health Canada Vision Care program. It's possible, but you have to go look for those possibilities, develop those possibilities, and implement those policies into your program. I stress often about the jobs, and that's because earned income directly affects the determinants of good health in so many ways. When I first put forward the plan at the Bigstone, we had 14 employees and no building except for a small health center. Today we have 130 employees and $6 million in capital assets, as I said, not including the health center. We are one of the largest private employers in the community and own and control a large segment of the business economy. Because of the growth within our business units, we are able to anchor the first shopping center for the community which is owned by the Bigstone Cree Nation and will open its doors in September of 2011 this year. This ensures our dominance in the business community as our town grows as a result of the exploration activity in and around the Bigstone traditional territory. In large part because of the transfer of NIHB, our health department has become a provider of service as opposed to a simple purchaser of service. It has allowed us to expand our services to other non-Health Canada related health services, such as the Industrial Medical Service, where we have 15 mobile medical service units and provide service to the oil and gas industry. We provide transportation for non-medical clients, and we are able to use capital from our business units to assist in the building of an Elders Lodge on reserve. This success, however, is not without its challenges.
Bigstone made the decision to build its own system instead of asking the insurance company to design and administer the NIHB program. And this was done primarily to save money, as the insurance industry was asking roughly 6 to 8% of benefits, of the benefit cost. And in doing this, what resulted more importantly was to build and retain corporate knowledge by training our staff that administer the benefit program today. One of the biggest challenges is finding balance between members' needs, government program guidelines, and the fiscal responsibility is a challenge that must be managed. Today, Bigstone, as part of its NIHB transfer process, has to guarantee a minimum of the current NIHB policy and guidelines as it delivers its program. Bigstone continues to have a grand vision to utilize technology to electronically integrate the NIHB systems in order to achieve efficiencies. Like any plan to have integration, the full value is never achieved until all staff are trained and organizational processes mapped and documented. Having the right management team is therefore important as efficiency planning moves ahead. One of the biggest things with regards to non-insured is the concern over financial risks. Managing this is going to be important as you move forward with managing non-insured health benefits. One of the risks, list of risks here that you have to be mindful of when managing non-insured is the enhancement on access to service and or expansion of the benefits list without identifying opportunities for savings or efficiencies. If you're going into this process in order just to enhance benefits tomorrow, that's a big risk because that's added costs on the overall delivery of the program. There's potential for increased misusers of benefits. They add costs as part of the ongoing operations. Improper record keeping on benefits is accessed by eligible clients. Now, I'm not familiar with your project today, but when First Nation communities agreed to deliver non-insured health benefits program, one of their primary requirements is you document all aspects of delivery of the program, because when they come and audit you, that's the information that you're going to be audited on. End of the Indian residential school program. Why this is here is that next year, I believe it's March 31st, 2013, is the end of the Indian residential school settlement. In Alberta, we have a large number of clients that access the health benefits, mental health benefits through this program. I doubt that March 31st, 2013, everyone's going to be fully healed. So there's potential there of all these clients being migrate back to the NHB program. So we have to be mindful of sunsetting programs in the near future. And it's always, from my history, is that if you don't negotiate the right agreement in the beginning, it's very hard to substantiate an increase after, because the rules and criteria in moving and trying to demonstrate that are a lot higher. But as with any risk can be managed, and without risk, there is no reward. So based on that, through the Bigstone Experience, the lessons learned in going through the pilot process of the non-insured health benefits project and moving forward with NHB under transfer is First Nation organizations can deliver the non-insured program independent of the government. But first, you must learn to deliver the program and recognition where government limitations and barriers can be removed in order to take advantage of opportunities. Must be ready and willing to manage the program different than government. And as you heard, as Barry has indicated today, owning health-related business is profitable, and those profits can be put back into the community, not only health, but also the other determinants. And we certainly want to appreciate the opportunity of being invited here today with regard for the presentation, and being invited a couple of weeks ago to make this presentation to the First Nation Health Council, and had an opportunity to speak with a number of management. Based on that assessment, we certainly see some opportunities for synergies between Bigstone Health Commission and the First Nation Health Council as they move forward on information sharing. We certainly have over 8 years managing all benefits, and 11 years managing NIHB as a program. Systems utilizations. Bigstone is making great efforts to develop systems, electronic systems. Bigstone is required under the agreement to ensure that the NHB program is available to all Bigstone members across Canada. So if a Bigstone member goes into a pharmacy in, let's say, St. John's, Newfoundland, we have the capabilities to ensure that prescription is adjudicated at site and electronic authorization is given immediately, similar to what ESI does today, and that the pharmacy is paid through our finance system. As well, I think we have an opportunity to work together and identify more efficiencies in the delivery of non-insured health benefits. But to achieve the opportunities available in the industry, it is imperative that you understand and know the risk of administering the NHB program and developing risk management plans to mitigate risk. In conclusion, with a good plan and strong support from leadership, we believe the transfer of non-insured provides greater opportunity than it does risk. However, the profits from the businesses can be seen as an insurance against higher cost and revenue, as these profits can back up a year when something unforeseen develops. We believe that the best insurance against losses is a healthier community, so that today our goal are building on the determinants of good health. And thank you, and we certainly appreciate again the opportunity to be able to do the presentation today.
All right, with that, ladies and gentlemen, let me ask you to join with me in thanking Bigstone Cree for that presentation. Thank you, Kelly. Thank you.